I'd like to welcome back to the podium Dr. Asirvatham from the Mayo Clinic, who will present the con side of the argument. And I will also beg your indulgence. I have a family birthday, and we're running a little late. I have to leave for the airport. So would you gentlemen stay on the podium and handle the questions as we end? Thank you all very much.
Well, very first time I debated anyone at HRS, I remember I saw a bunch of compromising photographs of myself that even made me blush, which is hard. And they had connived with my own family to get those pictures. So I'm glad this was an actual debate. Well, so in terms of disclosures, really, as I mentioned earlier, co-inventor on 2 devices. The only way that my bias will creep in here is if I decide to throw the debate. So can we be done with stroke prevention by closing the appendage? My view here is probably not yet. And few things. First, I'm sorry. It's the slide set that I had just given you, ma'am. It's not this one. We'll get that up in just a second. This debate, it should be right on your desktop. Yep, that's it. So stroke, I think first thing to think about when we think about appendage closure is stroke, we make the assumption is either hemorrhagic, which we can't do much with either anticoagulation or closing the appendage, or it's cardioembolic. And if it's cardioembolic, it makes a lot of sense that instead of giving a systemic approach like anticoagulation, that we focus on a local approach by closing the appendage. So the rationale is very clear. But we have to step back and look at a few things. The first is how often do we actually know that the appendage is the cause of cardioembolic stroke? You'll often hear this quotation or this figure that 95% of clots in the heart come from the appendage, and that's true, but it's a very small percentage of patients with atrial fibrillation and who have a stroke and have a concurrent TEE that you find any evidence that it actually was the left atrial appendage. And to me, this is always sobering, even beyond the debate, when you think about this, that you can't really be like we often heard as medical students, well, the clot's not there because it's gone to the brain. Because if you see those huge clots that are there in the left atrial appendage, this is not going to be some small TIA or stroke that that patient has. We recognize that there are LAA dependent and independent stroke, ischemic stroke, forgetting about hemorrhage, in patients with atrial fibrillation. Question is, how much of this do we really get rid of by getting rid of the appendage? And can we say today that that's enough and we don't really need to do anything further in terms of anticoagulation? We have to recognize that stroke is multifactorial. Even ischemic stroke, there's the issues of in situ thrombosis. There are issues even in terms of cardiovascular sources for stroke that have nothing to do with the left atrial appendage. And there's direct and indirect evidence to support this. We know even when you accept that the heart is the source for the clot, we discussed this morning that there are areas in the heart itself that are beyond the appendage that can be sources of small thrombi. These could be as a result of cardiac enlargement. They could be variations in anatomy. They could be simply spillover of what we consider as appendage, but into the left atrium. What about the issue of thromboembolic risk, even when there isn't atrial fibrillation? This, I think, there's two pieces of data that tell us a powerful message. First, one way you can look at the ASSERT study that's been referred to several times today is be careful of even small amounts of atrial fibrillation that are not clinical. That is correct, and that's for sure. But another factor from this study was there was no temporal relationship between when the atrial fibrillation was seen and when the patients had embolic clinical syndromes, including stroke. So there's an issue there that says, look, this could be an epiphenomenon. And if that's the case, don't focus all your attention on a part of the heart that you can implicate as a result of atrial fibrillation and stasis. Another way of looking at this is as we monitor more and more, especially in patients who have risk for stroke but don't have atrial fibrillation, we find atrial fibrillation. So in other words, what we are really managing in these patients is their risk for stroke. If that's the case, it seems like a stretch that getting rid of the appendage is enough to get rid of everything. So how important is it? Look at it from another view, the CHAD score. We appreciate the idea that the appendage can house a clot, but how is it the very same atrial fibrillation? We're fine giving somebody maybe aspirin or nothing at all, and another person with the very same arrhythmia, just as persistent, we give higher risk and we want anticoagulation or a device. How do those risk factors actually make that same arrhythmia more of a stroke risk factor? The data is very, very intangible and very small right now, where we can say these risk factors act on stroke risk at the appendage level. It's much more likely to be a more widespread phenomenon. For example, diabetes as an inflammatory process, hypertension. Many ways that you could think of hypertension as a risk factor for stroke. The atrium is one, but we also have issues related to the vasculature themselves, and some of these are clearly not hemorrhagic and potentially targets for improvement with anticoagulation per se. So when we think about the CHADS and CVA, we recognize there are two arms for this: getting to stroke and then getting to stroke via atrial fibrillation and via atrial fibrillation through the left atrial appendage. If we're just targeting a subset of one arm, it's hard to think that it's good enough in all comers with this syndrome to forget about anticoagulation. Growing story about inflammation and CHADS, it may be markers for each other, and guess what? AFib may be also a marker of the same process. We know that there are situations where beyond aspirin, we have to do something else in the absence of anticoagulation. This is, to me, was also an important story, and that is, even if you take away AFib, we have stroke risk with a high CHADS-2 score, even if you take away AFib. So how do these patients then get better with getting rid of the appendage? And if this is how we risk stratify with AFib, then there has to be an overlap in that rationale. Appendage ligation, as we've just heard, there are issues in terms of does it always work? So even if you forget about the epiphenomenon issue, can you get rid of anticoagulation? Well, it'll be good to see the data that was presented more formally scrutinized to see can you actually not give any warfarin at all. But we have a couple of issues. We know that there are times where it's not the leak so much that's a problem, but leftover pouches or leftover connections from lobes of the appendage. We also know that even when you get this very nice looking flush occlusion at the level of the ostium that's endothelialized, we know the most potent thrombogenic chemicals or chemotactic thrombogenesis is in the formation of new endothelium. So you have a period where you go to from a raw surface to endothelium that's paradoxically a higher risk for contact activation thrombogenesis. Now that's fine if you have very good blood flow, but in atrial fibrillation or when there is significant inflammation as a process of atrial fibrillation, that could be difficult to routinely, at least without prospective evidence, to say that we don't need anticoagulation. Finally, there's, I think, no question that some cases, that any time that this is happening, you do get complications, including acute thrombosis. Some of this is really procedural, and Coumadin itself may not have helped, but some of it, presumably, at least short-term anticoagulation will help. So to summarize, if we say left atrial appendage exclusion is a way to make up for all the issues that go in to make stroke risk in patients we recognize to have atrial fibrillation, it's difficult. The most powerful, I think, thing that we have to deal with in upcoming studies is this question of an epiphenomenon. It's kind of like I tell my patients, AFib and stroke is a little bit like gray hair and wrinkled skin. How much ever you like it, they go together. Don't like it, they go together. If you color the hair, the wrinkles don't go away. It's the same way, if you get rid of the appendage, the stroke risk does not necessarily go away. Thank you for your attention.
A very short rebuttal. We agree so completely. And the gray hair and the wrinkles is great. And your entire discussion would be compelling if it were true that warfarin had none of its own wrinkles. And that is the rub. We could just completely switch our choice of words. And the issue is not that stroke in this population is multifactorial. That is very clearly the case. And I think the TAVR data I showed with ongoing stroke risk after the early procedural strokes quantifies the risk and shows us that it is a disturbing mix of ischemic and hemorrhagic. So the question is not, is one or the other of these therapies perfect? It's, have we reached a floor for therapy for stroke rates with both of them? And the answer is yes. Warfarin reduces the stroke risk broadly in atrial fib from about 6% to 3% per year. That is a 50%, it's actually, most studies, a 60% reduction in stroke risk. And to say that you're better off with a device than warfarin is only to say that the device gets you to that same floor, that ongoing rate of stroke, the wrinkles that you can't make go away, is the same either way. And if you get to pick, would you rather live with those wrinkles and take Coumadin every day, or dabigatran or whatever, or not? And I think the quality of life data from the Watchman trial are compelling in that regard.
So 100% agree with that we cannot debate do we get rid of stroke with a device. Question is it equivalent to warfarin? The sub-wrinkle there is that warfarin, the issue then becomes, does warfarin address something more than the appendage? If so, do we have reason to use both? The second is, since intracranial hemorrhage is really the big worry with warfarin, factor 7 role in cerebral cortex, when and if we have a drug that clearly shows us long term, and maybe we do, that we don't have intracranial hemorrhage, would there be adjunctive therapy with a simple drug that doesn't need monitoring and maybe physically taking care of the appendage? But I completely agree. We agree more than we differ.